Dr. Cole comes from us, from Blue Cross Blue Shield of Louisiana, and is it tomorrow? So tomorrow, Dr. Cole leaves private practice and enters into the world of Blue Cross and Blue Shield, where he'll be the Vice President or Associate Chief Medical Officer and Vice President of Care Delivery. So we're excited to have Dr. Cole here to present to us today, and thank you so much. And with that, Dr. Cole, it's all yours. Okay.
So thank you for having me. And what I'd like to do today is give you an example of success, how care can be transformed and improved by using a health information technology-enabled platform. I did it, with the Lean Six Sigma project that I undertook. I called this project Pressure's On. And the pressure's on in many ways. I mean, the pressure is on because we have a healthcare system that's failing us. It's fraught with chaotic, disorganized, fragmented care that's way too expensive for the quality and the outcomes that it generates. And with regard to my project, the pressure's on with managing and controlling hypertension, because as a country we do very poorly. 50% of patients in general have their blood pressure controlled, and I think we can do significantly better than that, and I want to show you how. I want to do it within the framework, though, of talking about cookbook medicine, because cookbook medicine is a term that really is kind of derisively referred to by physicians. It's cookbook medicine, bad medicine. And it's almost dogmatic that they say it, with conviction that it is so. And I want to challenge that assumption, because I'm going to bring forth that I think it could actually be a recipe for success. So let's talk about something that I think is near and dear to anybody in Louisiana's heart, right? Cooking. In fact, the art and science of cooking. Because, there's two approaches to it, right? You can have a highly trained chef, someone who spent years of training, working, slaving in kitchens, maybe traveling abroad, learning how to cook in France. Somebody who is capable of creating something from scratch, right? Going into a pantry and taking a bunch of disparate ingredients that nobody would ever think to put together, and then somehow combining them into a marvelous concoction that tastes wonderful and looks wonderful, and they combine the art and science of cooking in such a way as to generate a culinary masterpiece. And when that approach is used, it's a customized approach, right? Each individual creation that chef creates is customized to the matter at hand. It implies tacit knowledge, right? This is knowledge that they've acquired over years and years of practicing and honing their craft. It's an iterative process, right? So in cooking, it's about, you add a little bit of this, add a little bit of that, taste it, kind of see what it turns out, and it's shaped as it goes. So each step in the cooking process is shaped by that chef's expertise and tacit knowledge and so forth. But there's another way of cooking, right? And that's just following a recipe. I mean, a recipe is something that it's explicit, right? I mean, it's just been honed over years and years. It's been cooked many times before. And essentially, all it involves is just following a stepwise protocol or recipe to generate the same outcome over and over again. In this case, it's programmatic, it's explicit knowledge, and it's a sequential process. So what determines good cooking versus bad cooking? I would contend it's taste, right? I mean, it's the finished product. It's whatever has been created, whether it was at the hands of a highly skilled chef in a 5-star restaurant, or whether it was somebody rigidly adhering to a recipe to create the desired product, it's the taste. Now, I will tell you, there's a price premium, right? I mean, so a 5-star restaurant by a highly skilled chef, you're going to pay more for that than if you go and buy the ingredients and whip it up in your own kitchen. Well, let's talk about the art and science of medicine, right? Because when doctors derive cookbook medicine, usually it's because they want to say each patient is unique, right? An individual patient, and I customize the care process according to the needs of that patient. And they do it in an iterative process. And you know what, look, that absolutely is necessary for a lot of medical conditions, okay? So let's take fever of unknown origin, for example. If a patient develops a fever that's been going on for a long time, and you as a highly skilled clinician need to apply all the years of training that you've accumulated to try to figure out what's causing this fever, you're going to do a detailed history, a detailed physical exam, you're going to order certain diagnostic tests. Based on the results of those tests, you may then order more tests in order to be able to try to come up with conclusions. So it's a matter of sort of hypothesis generation and testing until you can arrive at a diagnosis. And it takes a highly skilled physician to be able to do that. But, and in that case, it's the same things, right? Customized, tacit knowledge, iterative process. But you can also follow a recipe for certain. And in this case, you're following an algorithm or protocol. And it can actually be done by a lesser skilled person. It can be done perhaps by a mid-level provider or a team of individuals, like some nurses and some pharmacists who are just kind of following this under the direction of a physician, right? In a programmatic way. So what's good medicine versus bad medicine? Well, I would contend it's the same thing that cooking, right? It's the finished product, it's the outcome. It's your results. And in the sequential care process, the outcome typically is going to be directly related to how rigidly you adhere to the process. For an iterative care process, the success is usually going to be dependent upon the skill and the knowledge of that provider. Now, there are some potential problems here, all right? Because first off, go try to tell a highly trained chef that they need to follow a recipe to make a meal. It's not going to go over well, and the same thing unfortunately happens when you do this with physicians. Physicians will consider it beneath them. They don't want to have to follow a recipe. They want to use the skill and knowledge that they've acquired over years. And so there's a bit of an entrenched provider mindset here, a resistance to following a protocol that presents a leadership challenge and would involve some change management strategies to overcome. So why not use an iterative care process for everything, right? Well, the end result of an iterative process is variation, because no matter how good the chefs are, they're not going to cook the same thing exactly the same. And the same thing is true of physicians. No matter how good the physicians are, you're going to get variation. That's what we see throughout the country. Jack Windberg, founder of the Dartmouth Institute, all of his research has shown the widespread practice pattern variation, widespread outcomes throughout the country. That's a result of an iterative processes everything in medicine. So what determines whether we can use a sequential process versus an iterative process? Well, it's the state of the knowledge, right? Because let's take blood pressure, for example, right? First we had to learn that blood pressure was even an issue. That high blood pressure led to problems. Then you had to understand all of the neurohumoral mechanisms as to why high blood pressure evolved. Then they had to develop, pharmacological agents that target those issues in order to be able to treat and manage hypertension. So there's a state of knowledge that evolves, but eventually that knowledge form goes from the tacit knowledge to explicit knowledge, right? In cooking, it goes from knowing exactly what something should look like at a given moment in time to cook it continually. But in medicine, it goes to where if the knowledge is so advanced and we know exactly how to manage high blood pressure in an evidence-based manner, then isn't it just following the knowledge and ensuring the reliable application of that knowledge in a widespread manner? So that essentially, as knowledge evolves, the locus of that knowledge changes. It goes from a skilled artisan, like a highly trained chef, to somebody with lesser skill and training, somebody who can just follow a recipe. The same thing can be true in health. It can actually, there's replication post-test, right? So you can codify it into an algorithm or a piece of technology. Roger Martin wrote a wonderful book called The Design of Business, and this is a graphic in that book where essentially he talked about this evolution of knowledge. From mystery to a heuristic, which is kind of where we are with a lot of what we do in medicine. Each doctor saying, treating high blood pressure in their own individual manner, to essentially an algorithm that can indeed be codified and followed. Our current healthcare system, what can we say, right? Most expensive in the world, almost twice as expensive as the second most expensive healthcare system. Outcomes that really are average, lag behind many other industrialized countries, with as much as 30 to 50% waste. And yet only 55%, this is from the Glenn's paper in the New England Journal of Medicine in 2003, which found that only 55% of good, effective care actually gets recommended and gets done. So we have a lot of work to do with our healthcare system. if there's one thing about Louisiana, we know how to prepare for a storm. And I'm hoping that we'll be able to prepare for this coming storm of healthcare transformation as well as we can prepare for hurricane. There are a lot of things coming our way, and depending upon your vantage point. If you're trying to hold on to the status quo of our previous healthcare system, all of these are threats. But if you're someone who is willing to embrace a new healthcare system, a more higher performance healthcare system, these are all opportunities. So what we envision, this has been mentioned a couple of times today, and so I'll just build on it. What we envision is the transformation of our healthcare system from a volume-driven, transaction-based system to a value-driven, outcomes-based system, right? Think about if you're building a house and your contractor, basically the price of the house depended upon how many nails you had to pay for every nail, for every board, for every electrical outlet. I mean, think about how many nails and boards and electrical outlets this house can contain. And it wouldn't necessarily make it a higher value, better house, but it sure as heck would make it more expensive. So we have to undergo a transformation. And the first thing we need to do is envision the delivery system transformation. What would that delivery system look like? And then we're going to have to evolve some reimbursement mechanisms that will enable that transformation to occur. Because we've got to move away from fee-for-service. And I'll tell you, at Blue Cross Blue Shield, we initiated our first performance-based contract, something called Quality Blue Primary Care, where we're willing to put care management fees into play to providers who will provide better quality of care, better outcomes in chronic disease. So we want to incent improved outcomes. Ultimately, we do see things moving more towards some degree of shared savings, maybe some bundled payments, etc. But to do this is going to require collaboration between health plans and the providers. And so it's essential that we're going to move away from the traditional adversarial nature with health plans and providers fighting. Let's collaborate and work together to yield some better outcomes. So I'm going to tell you about how I use Lean Six Sigma, because Lean Six Sigma has been used in healthcare for over a decade, but it's been used primarily in an operational process. So, for example, door-to-balloon time, how quickly does a patient get from the front door of the emergency room into the cath lab where they can undergo angioplasty, things like that. I applied it to a clinical process, and that clinical process is hypertension. And so, in doing this, what we want to do, the story we want to tell is we want to improve outcomes. We want to reward providers who demonstrate improved outcomes. We want to actually help drive market share to those providers who are yielding the best outcomes. And then ultimately, we want to enable a value-based competition among providers that will compete on the value of services rendered rather than the product. A few Six Sigma basics, just so you'll know what the heck I'm talking about for anybody who's not familiar with Six Sigma. The term sigma is a measurement, basically. How far does a process deviate from perfection? So Six Sigma is actually near perfection. It's in talking about defects per million opportunities, it's 3.4 defects per million opportunities. So when this was first used by Motorola in the 1980s, they were making, I think, phones or something. If they made 1 million phones, only 3.4 would have defects, right? So near perfect. To put that into perspective, most healthcare processes are about 1.5 sigma. And so if you look at it up here, that's greater than 300,000 defects per million opportunities. We're not very good. It's also a quality improvement methodology, and that's the framework we're going to be looking at it today, where we apply the statistics to a process in order to try and improve that process. And then lastly, some organizations are using it as a management system to try and achieve success. A few key concepts. Critical to quality is the attribute of quality that's most important to the patient. So with regard to high blood pressure, it's whether or not their blood pressure is controlled. A defect is just not failing to control blood pressure. Process capability is going to be what the process can deliver. So we'll look at a baseline process capability, then we're going to look at a new improved process capability. And then stable operations is just how do we ensure consistent, predictable processes over time to ensure that a patient gets what they need. There are 5 separate blocks here. So the DMAIC methodology: define, measure, analyze, improve, and control. Define, we define the problem. We then kind of measure all of our initial data, analyze that data, and try to find out what are the critical X's, what are the things that are most important, as far as potentially causing defects, and then we work to improve it and then maintain that improvement. So the way I kind of came into this, I wanted to do Lean Six Sigma certification, and so I timed it with a campaign that was being mounted by the American Medical Group Association. So this is an association that my clinic belongs to, and they came out with this campaign, Measure Up, Pressure Down. They wanted to get 80% of patients at goal blood pressure, according to the JNC7 guidelines, and they wanted at least 75% of their organizations to adopt a campaign plan. And so the whole goal of this was how do we make it a national effort to control blood pressure. These are the processes that they came up with. They wanted 80% at goal. They wanted us to get direct care staff to be trained in accurate measurement, use a hypertension guideline, adherence monitor, make sure that you address blood pressure every visit, and then all patients who are not at goal, see you back in 30 days, and get a prevention, engagement, self-management program in place, use a registry to identify and track their high blood pressure patients. So these are kind of some of, this is sort of the framework that I used a little bit when I was designing this. There's a lot of disparity now over what's recommended. JNC7 said this, 140/90 for uncomplicated, 130/80 for diabetes. American Diabetes Association in 2013 said, no, let's make it 140/80. JNC8 just got published and said, look, 140/90 if you're under 60, 150/90 if you're over 60. But I will tell you, this has come under a lot of fire and is being heavily disputed. The metrics that I used in my project were 140/80 for diabetics, 140/90 for everybody else. Now, this is how we used to get data. So this was data from an organization called COSAC. And COSAC is a consortium of several southeastern states that really wanted to make it a goal to improve cardiometabolic risk factors in a population. All of this data was obtained by manual chart review, all right, no EMR yet. And we had 2 Louisiana sites. This was us, all right. And so you can see there's several things I want to bring your attention to. First off, national rate of hypertension control, 50%. In the southeast coast, sorry. So the southeastern United States, 65% was the average. We were 61%. Now, let me tell you a little bit here, because I'll tell you that the clinic that I came from, we really are very selective about the physicians we hire. I mean, let's face it, you really need to be kind of in the top of your medical school class. You know, there's an organization called AOA, Alpha Omega Alpha Honor Medical Society. And at my clinic, if you were an AOA, I mean, you might get hired, but it's hard. I mean, we value high providers. I always say that because I want to drill home the point that these are good doctors, very good doctors who achieve 61% control. And so maybe your ability to do something like achieve high blood pressure control is not necessarily related to how good you are as a physician. It's related to the processes that you have going, right? So the next thing that I wanted to bring your attention to is this, which is variation. All right, so look, throughout the southeastern United States, 46% to 80%, huge variation in rates of high blood pressure control. So I called my project Pressures On, and my goal was to take us 60%. This was data that I collected from our EMR and found that we were at 60%, and I wanted to get us above 80%. So why? Well, quite simply, high blood pressure is a big problem, right? A lot of major contributing factors: pulmonary disease, congestive heart failure, stroke, chronic kidney disease. I limited it to 18 to 80. I didn't want to include anybody over the age of 80 because, quite frankly, especially in the elderly, you don't want to aggressively lower their blood pressure. You know, they'll be at risk of falls and making them orthostatic, and so limited my scope to that. And it just felt like basically improving blood pressure control, in my mind, made perfect sense. I mean, kind of my business case was, look, you know, improving control in a fee-for-service environment means more visits, get them to come back to address their blood pressure and get it controlled. In a performance-based contract, you do better, you get money in a performance-based contract. And quite frankly, if we ever go to a world where we're taking on risk, fewer heart attacks and fewer strokes means more revenue there. So now, I knew there would be some issues, though. So this is a CAP tool, a change acceleration process tool, called a TPC analysis, where you basically try to foresee some of the barriers that you're going to run into. And I ran into a lot of these. And this was really, in my mind, the biggest one, because I think physicians, if you start telling them how to practice medicine, they feel a loss of their autonomy. They feel a loss of control. And I think that it can breed some professional resentment and willingness to change. There is disagreement regarding evidence-based guidelines, and so even if you kind of throw that out there, there are always going to be some physicians who are going to disagree with it. A failure to recognize the need for change. Quite frankly, there are some doctors out there who don't think the system needs to change. That, in fact, it's changing. Everything we're talking about is for the worse, and that the good days of practicing medicine are over. And then this is a big one too, especially in primary care. Primary care is already kind of overburdened. We have a shortage of primary care providers, and so what's happening is anything that increases work for physicians and their staff is going to create a barrier. And then, another barrier that I got, because when I went to my department, I said I want us to get greater than 80% control. And, the first thing I got was, that's ridiculous. Not possible. Can't do it. Not in Louisiana. And I made the foolish statement of saying, well, Kaiser in California, they're at 84% for over 600,000 patients. Oh, yeah. It's California. They're healthy in California. They eat right. They watch their salt intake. They exercise. Of course they're at 84%. We can't get better than 60%. That's as good as you're ever going to get. And then they cite things like non-compliance and our culture, right? Let's face it. We're about to go eat crawfish. There's a lot of salt in that crawfish. So things like that, were the challenges. But you know what? I felt like this means it's something we got to try, right? Because this is kind of the rate of heart attacks. These are our patients, our friends, and our families. These are strokes. So I think it's worth going there. There's a cost to this too, right? Because this is data from the Dartmouth Institute. And it looks at Medicare reimbursements per beneficiary. Louisiana is it's the second most expensive state in the country. New Jersey is number one right now, but just by a few dollars. So if you look at it, we're essentially one of the most expensive places in the world for health, with quality and outcomes that have us ranking 50 out of 50. So this was our baseline process capability. So when I did my data analysis in the Six Sigma lingo, defects per million opportunities, so we had 2,400 defects, 400,000 per million opportunities, so we had a Sigma score of 1.7. This was my statistical analysis. So I looked at the variables that I could most easily extract from my electronic medical record. I looked at things like diabetes, age, their BMI, who their provider was, whether they were a smoker. Everything I looked at was statistically significant using a chi-square analysis, except for cigarette smoking. Interestingly enough, no statistical correlation with smoking. And so let's talk about the results. So diabetes was statistically significant. So basically, what you kind of derive from here is that there are a lot more non-diabetics who are controlled than diabetics. All right, so red is bad, green is good, and so diabetics were more poorly controlled. Now, in large part, that's probably because we use a different measure too, right? So I held diabetics to a 140/80 standard rather than the 140/90 standard. Nevertheless, we did a worse job at managing diabetes. This was age. Now, age is interesting because I'll tell you, the bias among some providers especially was that, their older patients were going to be less controlled because they intentionally didn't control them as aggressively. And so that was kind of one of the things that were like, oh yeah, but my older patients are going to be less controlled. That's not what the data showed. The data actually showed that it was the younger patients who were more poorly controlled, not by much, but still. The key, though, was that it was the younger patients who were less controlled. I think that may represent some issues with medication adherence potentially, but regardless, it wasn't the story that the providers wanted to tell, was that the older ones would be more controlled. Now, this was the big one, right? Because that was what I got. The obese, we have so many obese patients. There's no way we can ever get above 80% because of all of our obese patients. Well, they were right. We do have a lot of obese patients. Okay? But look at the range in control. I mean, it was statistically significant, but it doesn't blow you away. I mean, obese, we had about 58% control among the obese, 54% in the extremely obese, compared to about like 65% in normal body weight. So, I mean, yeah, there was a difference, but not huge, okay? There was actually a variable that was way more statistically significant for failure to control blood pressure than any other doctor. The doctor. Whichever doctor was taking care of them. These are good doctors, okay? So look, this over here, we have a doctor, or here it is, 39% control. I know this doctor. He's a good doctor. He's got some bad processes for managing hypertension, but he's a good doctor. I would go to him in a heartbeat. But only 39% of his patients were controlled. Over here, this is the best in the practice, was right at about 76%. All right, now, this was me, okay? Having said that, I'm not going to take credit for it. It's not because I'm a better doctor than any of these people. It was that, I've been, for the last couple of years, I've followed algorithm. I mean, it's a no-fault algorithm. It's basically, I start with this drug, and then I add this drug. I see them back in 4 weeks, and I basically just follow this little sequential algorithm. And my nurse practitioner, I had a nurse practitioner that works with me, her number, she actually was at 78%. Her data is not on here. This is just the physicians, but nevertheless, I mean, she and I were doing the exact same thing, and we had a rate of control that was within 2 percentage points of one another. So when I got to the improve phase, then the question was, well, look, so right here I knew I was at 76% control before the improve phase, so I'm like, I can hit above 80%. I know I can get there. And I hypothesized, why might I not be higher? What's the issue? If I'm not above 80%, why am I not? And, I just kind of hypothesized, and I said, well, I tell people to come back in 4 weeks if their blood pressure's under control. But I don't really know how many are coming back in 4 weeks. So I looked at the data, right? And this is the data, right? So this is me, okay? I was the best in the department, and I was only at about 35% of my patients coming back. And 40%, something like that. So not many though, right? So if you had asked me how many of your patients come back in 4 weeks, I probably would have said 80%. But I was wrong. And some providers had less than 10% of their patients coming back within 4 weeks. And so I did the absolutely most simple thing in the world, right? What I didn't change the way I practiced. All I did was in our EMR, we have a little button up at the top. It's a remind me button, okay? And what I did is I flipped this remind me button, and a little screen comes up with the patient's name. And I type blood pressure check 4 weeks. Their name goes into a registry. And in 4 weeks, if the patient hasn't come back, their name turns red. And if their name turns red, my nurse calls and says, hey, you're due for your blood pressure. Remember your blood pressure was out of control, you need to come back. And then this really amazing thing happens. They come back. At least 80% of them come back. In fact, the newest data, I don't have it on here, but my newest slide would kind of be coming down there, 85% or something, come back within 4 weeks. So the summary of the improved phase was this. We went through some other things, right? So I did a vital station. We really put our nurses through a kind of a rigorous blood pressure measurement protocol. We wanted to make absolutely certain that our nurses were measuring blood pressure perfectly, right? I mean, it's essential for so many reasons, but we wanted to make sure the numbers were accurate. I developed a standardized evidence-based hypertension treatment protocol. It's the same protocol I've been using for a couple of years. We strove for these targets, like we talked about before. We added a little recall point in the feature in EPIC. Basically, we'd see them back in 2 weeks if they were over 20 millimeters from goal, and we'd see them back in 4 weeks if they were less than 20 millimeters from goal. And then I would utilize that remind me feature to populate that little makeshift registry to facilitate outreach and just ensure timely follow-up. I also created a brochure, an educational brochure for them to just kind of educate about the risks of high blood pressure, the importance of adherence to medications, and appropriate follow-up. Now, this is pretty busy and detailed, but this just gives you an idea. This is kind of what we created, right? So this was sort of the algorithmic process. Determine, just basically the first thing you do is determine how far away they were from goal. If they're greater initially, so if you're seeing a high blood pressure patient for the first time, then you would initiate combination therapy if they're more than 20 millimeters away from goal, and schedule a 2-week follow-up. If their blood pressure was not controlled, then you titrate the existing medicine. or you'd add another agent to follow the same kind of algorithm. And you just kind of loop on this until you get it control. And these are the medications. And so it just starts with this family of medicines, and then you add this family, and then this family. So nothing too terribly complicated. This was a measurement protocol, so this is kind of the training we took the nurses through to just make sure that they had a process in place for how to check blood pressure. Because you're supposed to check it. I don't know how many of you have had your blood pressure checked recently, but let me describe to you what's supposed to happen, and then you can judge for yourself in the future if it's happening. Because what's supposed to happen is you're supposed to be seated for 5 minutes before your blood pressure is checked. Both feet are supposed to be flat on the floor. Your back is supposed to be supported in a chair. Your arm is supposed to be supported at heart level, not you. It's supposed to be either resting or the person checking your blood pressure should have it supported. The provider should be using the bell of the stethoscope, not the diaphragm. And that's proper blood pressure checking. And I guarantee you there's not probably a lot of providers who are doing it quite that effectively. So what were our results? Well, this was kind of the pilot case. So what I did is I took 10 physicians, and I took, a lot of these are some of the lower performing physicians, and tried to see what we could do as far as getting them to improve. Now, I was encouraged by it, and I was also disappointed by it. I was disappointed by it because there's stuff like this, right? This guy didn't improve at all. And what I can tell you is, wasn't following the process at all. Some made an effort, and we did see some pretty good improvements. I mean, we had 4 physicians get to the 80% mark. So realizing that when I started this, we had people saying, "Oh, you'll never get above 80%," and I got 40% of these physicians up at 80%. Me and my nurse practitioner both got to above 90%. And the 90%, I'll tell you, this was several months ago. Where we are now, we pretty much held it steady for about 8 consecutive months, where we were between 90 and 94% for 8 consecutive months. And I can tell you that we adhere very rigidly to the process. And so the biggest message that I want to make sure comes across is that 90 to 94% control of hypertension is possible. And it's possible in Louisiana. And if it can be done in Louisiana, it can be done anywhere in this country. And I would love to see us try to make an effort to scale this so that the entire population of Louisiana who has high blood pressure are controlled in 90+. So the summary and conclusions here, our baseline process capability, 60%, diabetes, BMI, age, all statistically significant, but paled in comparison to the fact that the providers are most statistically significant. Adherence to a standardized protocol can generate 90% as a new improved process. Achieving scalability is going to present a leadership challenge involving change management strategies and overcoming lots of entrenched provider mindsets. But the process can be codified in such a way as to allow clinical personnel with lesser skill and training to achieve a much better process capability. And so envision for me a world in which payment methodologies are aligned with value and outcomes, where teams of providers, nurses, pharmacists, mid-level providers are managing populations, and the populations are segmented such that you're managing your complex patients in one way, you're managing your at-risk patients in another way, your young healthy patients in a different way, and patients with high blood pressure are easily managed with a codified algorithm that can be run by someone with lesser training. The busy primary care physician who is like a hamster on a treadmill just trying to see more and more patients doesn't have to do that because it can be run by others, mid-level providers, et cetera, in order to generate those outcomes. And that way, they can be, those primary care providers can be the highly trained chef, the highly trained clinician who are trying to deliver care with the iterative process for other medical conditions that can't be codified into an algorithm. Now, to do it all is going to have implications for design and care delivery, and it's going to involve new payment methodology. Fee for service doesn't work for what I want to do with outcomes. And convincing providers to come on board and accept new payment methodologies that are going to reward improved outcomes, I think would be somewhat difficult, but it's essential if we're going to generate a much healthier state. So right now, the story in Louisiana is we're the worst. And the story that I would love to tell is that we are an innovative state that can really do some cool things. Because Lean Six Sigma and what I just applied to hypertension can be applied to lots of other things. And at first glance, I know if there were some physicians in this room, they'd think I'm nuts for including some of these on here. But believe me, diabetes can be codified, cholesterol, congestive heart failure, HIV, asthma, respiratory tract infection, even depression, lots of cancer, even approaches to chest pain and back pain. And there you can incorporate evidence-based processes, refine, improve, and generate outcomes that will improve quality and lower cost. And I would love to think about it.
With such good outcomes and improvement by you and your nurse practitioner, how is that perceived by the doctors in the practice? It seems like that they can adopt those methods.
And they're inching it. They really are. They're inching. I mean, you know, when I started, and look, I started this project, we actually kicked it off. Our baseline data was obtained in February, March of 2013. The very first month of improved was July and August. That was my first set of data. So not even a year ago, it was 8 months ago. And so it's still new. We were 60% when we went into this. Right now, as a department, this is 27 positions, we're about 74%. So, I mean, we've improved. We're better. Quite honestly, I think that, so I was a bit unique in that I kind of saw this coming. That was actually why I had hired a nurse practitioner. I was the only doctor at my clinic to hire a nurse practitioner. And I was a heretic for doing it, believe me. I mean, I was widely criticized for daring to do that. How dare I bring a low-quality nurse practitioner into the practice of all of the wonderful. But look, here's how I saw it. I saw it exactly this way. I saw it as, look, I'm going to teach my nurse practitioner exactly how to manage respiratory infections, back pain, et cetera. And I'm going to let her see all the simple stuff. And I'm going to focus more on the harder stuff. So I went from seeing 25 to 30 people a day to I saw 16 to 18 a day. She saw 12 to 14 a day. So we saw the same number together as we did, but I focused on trying to improve quality. So for me, a lot of this was me really taking it upon myself to do this and do the extra clicks and things like that. That doesn't go over well with doctors who are still trying to see 25 to 30 a day and do an extra click. It's like, okay, I can't handle what I already have. And so unfortunately, I mean, we made some improvement, but I think that's why I didn't see everybody at 90%. Now, if we can get some work, some improved work processes within the wall. You know, right now we actually don't have a quality department. We don't have a person who can go and sit with providers and kind of take it through. I mean, so I'm actually, it's one of the things I'm going to do at Blue Cross. I mean, I'm going to go to Blue Cross. One of the first people I'm going to hire is going to be a black belt Lean Six Sigma process improvement expert. And then I'm going to take her, and I'm going to insert her into practices. And I'm going to say, help them work their processes a little more so that they can generate these outcomes. And so if that's something that a health plan has to do, fine. You know, we can do it so that practices don't have to invest the resources. And hopefully by doing that, I'll get them all.
Ken, I'm very excited to hear that last piece, you know, as a healthcare provider. Just wanted to offer you a suggestion. After months and months and months of trying to improve turnaround times and also delays in surgery, what we found was the best way with physicians, they're very competitive lot. And so we quit blinding the data. We put their names on it and we posted it in both the lounge and the bathroom. Within 1 month, everybody was up to best practice.
You know, and so
that's how competitive we were. So just a suggestion.
Well, and no, and I'm with you. So I'll tell you what I did there because the data when I showed it to the providers, it was not one. I mean, I put names. And you know, the provider who had the worst blood pressure control was the provider I deeply respect, and I really think he was hurt by it. And I felt bad. I mean, I just kind of, so we had lots of follow-up conversations after that, and I think he's finally kind of eventually going on, but it took months. I really was under the impression, and this to me was it was a leadership lesson, if you will, because I really was under the impression that that was what I thought going in. I thought, look, they're so competitive. The second they see somebody really shoot up, they're going to be after to it. I kind of underestimated it though, because they're competitive, but they're also overworked. I mean, they're so slammed with volume that in the EMR. I mean, we just adopted the EMR, not that long ago, and so I think just getting used to the workflows within the EMR and now throwing on a little bit extra work on top of it, it was a tough filter.
Love the algorithmic process, but I guess my question is, for most of the processes that you mapped out, you guys, your providers, your medication prescriptions, all of that's within your control. How much, though, of the quality outcome is based on patient engagement and maybe something that the patient needs to do, change, or whatever?
So, I certainly think that was the key in going from, where we were at 76 to 78% to about 90%. That was all patient. I mean, I can promise you, I didn't change the way I managed my blood pressure one bit. I was still doing the same thing. It was really just a matter of proactively outreaching those patients. You're right, though, in that there is a big part of this, which is going to be things like lifestyle and sodium intake, and so I do think there needs to be a patient engagement strategy that is above and beyond this. But I'll tell you where I was getting kind of tired of. I was getting tired of providers throwing out the term non-compliant. I mean, I really just it started to grate on, because it's like this. Folks, they're non-compliant. This right here, I mean, not coming back in 4 weeks, that wasn't non-compliance. That was well-intentioned forgetfulness, right? Life is busy for them too. And so they leave the office and they, life is busy, work gets in the way. They need to come back in 4 weeks, they forget. And when you remind them, they come back. So,
I guess my concern is that physicians are, possibly looking at revenue-based portfolio, all the factors are within their control. Maybe that's an acceptable scenario. But once things are outside of their control, I can see if I was in this situation, I'd be a little concerned about I can't control those factors, but yet you're basing my revenue, on that.
Absolutely, and that's what gets thrown out all the time, right? The whole patient accountability, right? So it's how dare you hold me accountable for their behavior? And what I'm going to say is that we need to evolve processes of care that help to shape that behavior. So, and that requires education. And that's where health planning can come into play too, right? Because if we're trying, if a health plan is trying to help engage that healthy behavior as well, we're collaborating and working together, or usually it's our route.
My question is just in terms of number of different things steps that you took in order for this improvement from 60%. And a lot of situations when you try to improve, maybe the first 10 or 20% might come easy, the next 5% is harder to come, and then the next 1% is even harder than that. So do you have any sense of where your easier gains were and where, are you at a point where even 1% or 2% gain would be pretty hard?
I think that I think we'll still be able to get. I don't think we're there yet because, to me, the new improved process capability is 94%. That's kind of what, to me, every provider should be there. And getting them there, I know if they rigidly adhere to the process that's in place, they'll get there. I know it. I'm just 100% aware of it. The issue to me now is the change management strategies that need to be employed to get the providers to understand that. And what I do hope, and kind of back to what Dan was talking about, what I do hope is that we're entering into an era of transparency.
where all of this stuff is just out there. And where providers can then begin to look and see where they are in comparison to others. And basically be like, well, no, there's no way they're going to be better. And that we can then just teach them how to go about doing this. I mean, the key is we're not trying to tell providers that all of medicine can be algorithmically protocolized. I mean, I've got to get the message across that it really is these two different approaches. That some of it can do, and if it can, let go of it. Especially if you're not trapped in a fee-for-service model where you're just having to crank out visits all day long. Let's go ahead and just reward you for these outcomes so that you can then focus on other stuff and let others follow that algorithmic process and get those results. Because I think that's where we're going to realize the game. Because right now, what you've still got is entrenched provider mindsets who still just kind of doubt the data. They're just not on board realizing it.
Thanks very much. This was really insightful and encouraging. And I'm just curious, out of your analytics that you did among the different physicians, aside from process, did you notice any other similarities between the high performers and the low, whether it's continued education, demographics, anything else that might be able to assist?
Yeah, we loosely looked at demographics. They were all very similar. The one patient population that you can kind of exclude from this is Medicaid. We don't take Medicaid, so I'm sure if we had Medicaid in here, the numbers would have been quite as good. But otherwise, every provider has similar demographics, and really the one contention among the providers was the age variable. There were some providers who were like, "Oh, you can't. My data is going to be off because I have a geriatric practice, and so all of my older patients are not going to be as well controlled." Well, again, there were two things. One was I didn't include anybody above the age of 80, so that is out. And when I sub-analyzed, so those providers who were just arguing that, I sub-analyzed their data, and their younger patients were all more poorly controlled than their older patients. So as far as continuing education, no, we didn't look. I didn't look specifically at that. I did try to speak to the highest performing providers as much as possible, and each one of them tended to have their own sort of algorithmic strategy in their head as to how they do.
Any additional questions for Dr. Cole? Thank you very much. And good luck on your first day tomorrow.